work that we're doing within the team, we have a theme of work specifically focusing on decluttering low-value safety practices. And the use of the word clutter came from Drew's paper of 2018, where he talks about the accumulation and persistence of safety work that doesn't actually contribute to operational safety. And he referred to it as safety clutter, and we just loved that term. And so we've used it ever since. Just to tell you a little bit about Drew, who we met at a recent international group where we brought together people who are really interested in de-implementing low-value safety practices. So Drew is an associate professor in safety science at the Safety Science Innovation Lab at Griffith University. And Drew, you both teach and research, and you lead the lab there, as far as I understand it. Drew's own research is a mix of kind of field experiments, ethnography, which I know is something that a lot of members of the team do here, and he does theory building work to investigate organisational safety practices. He's particularly interested in understanding some of the kind of myths and rituals and bad habits that surround the work of managers and safety practitioners. And I think it's some of those and the transfer of automatic, without thinking, transfer of safety practice in industry into healthcare that he's going to talk about us today. I also want to mention that Drew co-hosts a podcast series called Safety of Work, which is fantastic. And I know a number of members of the group have been listening to some of those podcasts. And at the same time, I want to do a shameless promotion of our own podcast series called Stories of Safety, which is very much focused on safety in healthcare. Drew is also on the editorial board for, I know it's a journal that we often submit articles to, and that is the Journal of Safety Science. So without further ado, I'd very much like to welcome Drew to present today. He's going to talk for around about 40-45 minutes, and then we'll have some questions. Thanks, Drew.
Thank you very much for the kind introduction, which I did not at all right. And welcome to everyone who's joining us online. I don't think you can see me very well unless I stand here for the moment and say hi, after which I'll disappear in the background and you can watch the audience and the slides. Just by way of background and disclaimer, I'm an engineer by original training. My first job was for the Australian Navy. My next couple of jobs were for railway design organisations. After that, I worked in the Department of Aeronautics. After that, I worked in the Department of Computer Science. I'm a cross-industry safety researcher, which means that it's mostly my job to go to industries and be told I don't know what I'm talking about because I don't know the specifics of that industry and the challenges they face, and how things really, really are different there. But I have the advantage that I can see patterns that occur across industries and see a lot of the problems that people face that they think are particular to their own industries are not in fact particular to their own industries, but are recurring problems that occur in eerily similar ways. This is like everyone has that same dream where you're sitting in the backseat of the car trying to control it. It seems very specific to you. And we discover that lots and lots of other people have had that exact same dream. There's like 3 or 4 people in the audience nodding, and everyone else saying what they're actually talking about. Things eerily similar occur across industries. So if you've ever sort of thought to yourself, oh, we're not nearly as mature as those other industries, every industry has thought that. If you've thought that won't really work here the way it works in other places because our industry is much more complex, we have to deal with systems of systems, we have to deal with a particular type of bureaucracy, really weird power structures. None of those things are healthcare specific. They're all things that are experienced in very similar, eerie ways across other industries. So that's what I try to look at, is not trying to solve the particular problems faced by a particular organisation, but to try to understand what are some of these recurring patterns and what can we learn from the fact that the patterns occur even when the context changes. does that tell us something interesting about what's actually going on? That maybe it's not for the reasons that we think it's happening, if those reasons are not contingent or context specific.
Down button, I think.
That button does not like me. So I ask pretty much 3 questions in all of my projects. The first one is I try to understand, how do people explain their safety practices? So why do they do what they do? And if you ask them why they do it, what do they say? What are the sort of like underlying rationales for some things that might not even make sense to outsiders? I then ask, how do these explanations compare to what actually happens? Now, it's a very arrogant thing for a researcher to do, to tell someone that they don't understand their own work, to say that your explanation for what you're doing doesn't make sense, and I want to substitute my explanation as an outsider. But one of the things that gives us the right to do that is when someone's explanations do not make sense, as in literally are impossible to be true. There's got to be something else going on. And that's when I ask, what else might be going on here? How is it that these practices exist, contrary to people's own explanations of their own environment? People are not stupid. People are not irrational. People do not deliberately make work hard for themselves and other people. It is very, very rare to have someone who is genuinely toxic, in the sense of genuinely trying to make things hard or bad or non-productive. So when people are doing things that are making work harder for other people, making work hard for themselves, there's got to be something happening there that is worth understanding and explaining. So, example that occurs in every industry is risk assessment. We call it all sorts of different things. In the construction industry, they often call it Take 5. It's a checklist that you prepare just before you start work. In the chemical industry, they call it instead a pre-task risk assessment. In some high hazard industries, they call them safety cases or specific techniques that fit underneath safety cases, such as fault analysis or quantitative risk assessment. Every one of those people who does those risk assessments will tell you these are not the same as the other risk assessments, and they will carefully explain to you why their risk assessment is specific and different and has a particular purpose. Here is something that is universal about risk assessments, is that none of the people doing risk assessments have time machines. It is literally impossible for a risk assessment to influence a decision if that decision happens before the risk assessment is undertaken. This is a recurring pattern with every single type of risk assessment. When you closely examine it, the relevant decision happens first, the risk assessment happens later. Not as an aberration, not as a misuse of the risk assessment, not as a, this is a person cheating, this is a person filling out the form in the canteen the day after. This routinely and regularly happens with risk assessments. When people tell you we do risk assessments to inform our decisions, that cannot possibly be the explanation for the risk assessment. When this occurs in every time and place across every industry, this can't just be a weird quirk. This can't just be a couple of irresponsible people. This can't be dumb. There's got to be some purpose of the risk assessment, which is not influencing the decision that happens afterwards. That's a question I'm still getting to grips with, is exactly what are risk assessments for? But I can guarantee they're not for helping us make better decisions. And there is no evidence anywhere that risk assessments do in fact help us make better decisions. Even if you look at things like clinical risk assessments, papers that study them tend to try to explain why doctors don't follow the risk assessments, right? Clearly, the thing that we've got to explain here is not how does it help the decision, but why does it not? Why is it disconnected? And one of the reasons is doctors don't use clinical risk assessments to make decisions. They make decisions and then they do clinical risk assessments. Maybe it is to explain the decision. Maybe it is to make the decision defensible. Maybe it is for the organisation to reduce its uncertainty and anxiety about decisions that it has no control over. I think sometimes it's because we know the decision actually undercuts some of our values. And in order to defend a decision which undercuts our values, we need to have a value-based way of rationalising the decision. I say all of these things speculatively because we're getting inside the brains of people, but inside almost the emotions of an organisation, which is a very difficult thing to unpack. But the straightforward explanation that this is a tool with a function, that we can evaluate the effectiveness of the tool based on the reported function, is never going to work. We can't get rid of risk assessments by doing a controlled placebo, all the different things we go into gold standard experimentation trial to measure its effectiveness. Because all of the assumptions we need to do such an experiment simply aren't true. We would have to create such an artificial situation to do the experiment that we wouldn't actually be measuring real risk assessments. We'd be measuring this weird quasi thing that happens in psychology labs. And that tends to happen whenever we try to study decision making, is we get these nice neat effects that do occur inside the white walls of undergraduate students doing carefully controlled experiments designed by postgrad students. And then out in the real world it disappears because that's not how people actually make decisions. Give you another example, incident investigation. Again, something every industry does. Widely explained. Why do we investigate incidents? We want to learn what went wrong so that we don't do it again. Straightforward explanation, patently not true. How do we know it's not true? Because most incident investigations don't make recommendations to get implemented. Worse, we don't typically even set aside resources for implementing them. Most organisations that have an investigation budget don't have a corresponding actions from investigations budget. So clearly the rationale isn't the real reason. There's got to be something else going on, got to be some other reason why we do incident investigations other than the purported explanation. So I don't know if any of this is making you uncomfortable. It makes me deeply uncomfortable. Early on in my career, engineering background, I thought this was my problem to try to solve. Here are all of these practices that don't do what they're supposed to do. Gosh, we've got to redesign the practices so that they do what they're supposed to do. And then I realized that no one really wants to do that. I was like, okay, we've got to at least do some controlled experiments to develop an evidence base for what works and doesn't work. And then we'll use that evidence base to change the practices. Again, no one really interested in doing those experiments. Willing to spend the money on the practice, not willing to spend the money on knowing whether the practice works. At first I got frustrated, then I got angry, then I got curious. And I realized actually the problem to be investigated is not do these things work. These things do not do what they say on the tin. Every industry faces them. Every industry has very similar practices. Every industry has very similar rationales for those practices. Every industry has very similar reasons why they can't possibly work as they're supposed to work. That is fascinating. Clearly, we don't understand really why these practices exist. What we do know, and this may come as a surprise, is we have pretty uncontroversial evidence about exactly what makes people safe. There are only 4 things in the world that have ever been established to empirically make people safer at work. Whether it's patient safety, whether it's healthcare worker safety, whether it's digging holes on a construction site, whether it's blowing things up. What influences your safety? Number 1, the physical environment you're in, including capital equipment. If you are at heights, you're unquestionably more dangerous than if you're on the ground. If you're in a moving vehicle, you are unquestionably at more danger than if you're standing still. If that vehicle has not been well maintained or is old or doesn't have safety equipment, you are unquestionably at more danger than with a new piece of equipment with better safety protection in it. Some environments are intrinsically more dangerous. We know almost certainly what those environments are. We can very easily make decisions, if we have the money, to change those environments. Number 2, the people who are around you. The place you are at most danger is if you are working alone and far from help. If for no other reason, we know you're at more danger, because if you get injured, that injury is going to have much likely chance of a fatal outcome if there is no one to call for help. Other people around you who are looking out for you make you safer. Now, we're not talking here at the margins. We're not talking here about we do a little bit of team training and suddenly you're safer. Or we put up a few posters on the wall that might influence the safety culture and you're safer. We mean serious investments in staff, so you've got 3 times as many people in the emergency room looking up for people. We mean serious investments in personal capability, so that those people are trained, they're not just security guards. Those unquestionably make a difference to safety. Third thing that makes a difference is how the work is performed. Now, this one gets really controversial, particularly as you get deeper and deeper into safety science circles. You'll get people who say things like, there is no one safe way of doing every job, and human error doesn't really exist. I'm not personally that far in that camp. I think a lot of what we consider to be safe work is very much socially constructed. I also think for any job in the world, there are some ways of doing it that are safer than other ways of doing it, at least in that particular moment, in those particular circumstances. We can also, if we want to make things safer, fundamentally change the way a particular task is performed. Can make a big difference. And everyone in healthcare should know that, because that's like how healthcare progresses. Is we replace one drug with another drug, we replace one procedure with another procedure, we find a better way of doing it, and we systematically do that better way of doing it. We systematically get better outcomes. That's true of any type of work. Probably not true at the margins, where we replace Joe with Phil, and we think that suddenly Phil is going to make fewer mistakes than Joe. And the fourth thing is the tools that people have in their hands. And again, we're not talking about risk assessments, we're not talking about something on the screen, we're talking physically about what they are holding makes a big difference in their safety. You can almost predict the future of whether someone is going to get hurt as whether they're using a box cutter or an angle grinder. One of those is more dangerous than the other. For any given job, one of those is probably going to be the most suitable tool. Put all this together, we have our formula for an accident, which is a person who is in an unsafe environment, working alone, they don't have the right tools for the job, so they're jury rigging it. That is the story about how someone dies. That is a story that repeats over and over about how people die. How do we make people safe? We invest in the environment, the physical environment that they're in. We invest in the people and we make sure that there's the right number of the right people. We make sure that the work that they're performing is a suitable way of doing it, and we make sure they've got the right tools for the job. Now, we know all this. We've known all this for decades. Decades is probably only cutting it. We've probably known this for hundreds of years. It's just the nature of those things has changed a little bit. The real challenge is we cannot reliably do all of those things. And so this is why we build on top of systems and procedures and risk assessments and investigations, not because we don't know how to keep people safe, but because we don't know how to reliably keep in place things that keep people safe. Moreover, and this is the thing that people really don't want to hear, we do not want to do those things. We've got a project we've been running for a while, looking at pediatric sepsis. And the question is, why do people in emergency rooms not follow the pathway protocol that we give them for managing pediatric sepsis? There are very good reasons why not. We know what we need to do. What we need to do is redesign the space so that people have proper sight lines, people who are sitting down so that they can take constant attention to them. And we need to make sure that there's enough staff, both so that they can continue to pay the attention and so that they have no hesitation in sending someone to the back, knowing that the person there has got the time and space to actually treat the person. We're not willing to invest in either the space or the staffing. So we've already decided this is a problem that we're going to live with. That's actually the problem here, is not how do we design a better pathway or a better risk assessment. The problem is we've decided not to do the things that would make it safe. And we're tinkering at the margins, thinking, having failed to actually invest in the safety, what else can we do? And no one wants to hear that the answer is, sorry, you already decided to kill a kid. You don't know which kid, you don't know when, but you've already decided not to make the investment you needed to make. There is no form in the world that is going to undo that major decision that you made. but we don't feel good about it. We feel terrible about it. As a society, we are not allowed to even admit that we routinely make these sorts of compromises, and we routinely trade off the safety of individual patients for the efficiency of the overall system. We routinely trade off the safety of individual workers for the construction of infrastructure that makes the whole country work better. We make those trade-off decisions. Why do the risk assessments exist? Why do the incident investigations exist? Once you realise they're not there to save the lives, they're there to make us feel okay that we've already made the trade-off decision, and they are very good at it. Now, there's a little thing that I don't want to make people too uncomfortable here, but those of us who are in initiatives like decluttering, we're kind of the enemy, because this only works if you don't point out to people that the risk assessments don't work. Once you actually point out to people that a lot of this stuff is a waste of time, it stops being effective at making people feel uncomfortable. And I have a sneaking suspicion that the job of a safety professional, including a patient safety professional, is to make the organisation feel comfortable. And that we're actually not doing our job once we start getting too skeptical and start asking questions. But I don't think we need to be cynical about this. I think there is opportunity for clarity in thinking about this, also to go hand in hand with making us more effective. And that clarity requires us not to sweep under the rug those things I've been talking about. It requires us to have open conversations about those things. This is the whole point, by the way, of the term safety clutter. This is not an accident. This is trial and error with language over many years to find a way of having conversations about safety that does not work, that were safe to have. Because across industries, saying the risk assessment is bullshit makes it sound like you don't care about risk. When actually, you're the one who really does care about risk. That's why you're worried about the fact that risk assessment doesn't work. But you've got to have a safe way of having that conversation. You've got to have a safe way of saying, because I care about safety, I'm going to tell you that this induction is nonsense, but I'm walking out, and I'm going to spend my time on something that actually helps safety. That is not a safe thing for someone to do on a construction site, but it's what's necessary if we're going to actually make the induction more effective. So that's why decluttering. And I think that's partly why decluttering hasn't quite succeeded in healthcare and why you switch to terms like de-implementation. Because I think de-implementation matches the language of safe conversations in healthcare. People are used to talk about implementation. It's a nice mirror to talk about de-implementation. It's another very clever, safe way of having a conversation that doesn't sound like I don't care about patient safety. So this particular slide is like the product of maybe 15 years work. It's not a lot for that amount of work, but 15 years trying over and over to have the same conversation with people, both a conversation started by me and a conversation started by them. What is a good way to have that conversation? This is what we came up with. Is there are two different things we mean by safety. One of them is the safety of work. So when we talk about patient safety, that is literally what is the chance of the patient being harmed. The other is the safety work. That is also, we would call it patient safety. What we mean is this is the risk assessment, this is the procedure, this is the management system. Both of those are safety. So we need to give them different labels and recognise we're talking about different things here. There is safety and safety. There is safety of work and there is safety work. Once you make that distinction, you can start asking more experimental style questions, like what sorts of safety work have a positive influence on safety of work? What sorts of safety work do not have a positive influence on safety work? And this is where we got really careful because we don't want to call this nonsense. We don't want to call this admin. We don't want to call this bullshit. We don't want to call it paperwork. We don't want to call it mindless administration. We want to say this has got to have some other real important purpose. It is legitimate. It's just not legitimate for the reasons you think it is. What are those reasons? And we need to be honest about them. Those reasons are, we need to demonstrate to other people that we are safe. Why do we have laws about patient families and appropriate responses where patient families raise concerns? Is that because patients' families do in fact improve the safety of patients? In some well-defined cases, yes, and we really need to investigate that very carefully. Because a lot of those rules and laws are not for that purpose. A lot of those rules and laws is we've got to demonstrate to the patient's family that we care about safety. And only when we honestly say that sometimes they're raising a concern we need to listen to, and sometimes they need to be explained to and appeased and satisfied. Both of those are important and legitimate. When we mix them up, we do things like not listen to a warning that they were telling us that there was an error that we really needed to know about. But also when we mix them up, we launch a 6-month investigation into a totally routine, normal, appropriate clinical decision that someone was just upset about because it didn't have the right outcome. We've got to be clear about why we're doing it. We also do a lot of stuff which we put under the umbrella of social safety. This includes almost anything you might think of in terms of safety culture. Slightly open question whether it includes what we're sort of moving into talking about the psychological safety, because some of those things do have a direct impact on safety of work. But a lot of them are to make us feel good. Pretty much a general rule, if it's on a poster, it's there to make you feel good. If it's got the name safety in it, it's probably there to make you feel good. A lot of those things are there to make us feel that we are caring about safety, not to make us actually care about safety. And then administrative safety is safety needs to fit within organisational systems. And those organisational systems have lives and reasons of their own. If we didn't fit safety in with the way we tend to run other things in our organisation, safety would disappear. So a lot of safety work is actually running a safety management system that mostly consumes itself, but occasionally spins off other outcomes like being able to demonstrate safety. Every time it gets audited, it becomes demonstrated safety. Every time there's an incident and we say we didn't follow the system and we fixed it now, that becomes social safety. Or we're running the system to run the system, that's administrative safety. Or the system actually changes something about safety of work. It causes us to buy a new tool. It causes us to redesign the waiting room. Then it becomes safety of work. Okay, probably about time I got to the actual advertised reason for this talk. One of the things that happens across every industry, and again, you remember healthcare is not special, healthcare simply mirrors the same patterns we see everywhere, is almost every industry has envy about other industries and thinks we're doing things terrible. There must be someone else out there who's doing it really well. Let's learn from them. We can always pick to particular moments though when healthcare decided to look at aviation. I don't know if I'm overblowing this, but I think the To Err is Human report was particularly influential in the framing of patient safety and in this real aviation envy. That, you know, we kill patients far more often than they crash airliners. Therefore, they must be doing something right and we must be doing something wrong. Why can we not be as reliable as them? A couple of you are shaking your heads, and I think you can sort of like see the nonsense of this. Firstly, the aviation industry crashes far more planes than they admit, right? We look at the numbers for scheduled large body passenger jets and we think this is safe. Look at the number of small planes that routinely crash. You won't want to fly again. Spent a chunk of the last 6 months looking at air traffic control in Australia. Don't go flying in Australia the next couple of years, guys. Once you look inside any industry, you just start. I have trouble with intersections with traffic lights because the best advisors don't program traffic lights. And you look inside how they do those things, you wonder how they manage to be not green in both directions at the same time. Every industry has this habit of, if it's invented somewhere else, it might be good. But if we're doing this, we've got to ask some fundamental questions based on what actually improves safety. Safety is about the physical environment. Is an emergency room or a ward or an operating theatre anything like the cockpit of a 787? No, we are not working in anything remotely the same environment. Their environment is very controlled about who can go in and who can go out. Their environment has a lot of space around it. Their environment has surprisingly few other systems that are interacting with it, and those interfaces are all very well defined. This is not the same physical environment. Don't go redesigning your operating room to look like the cockpit of a 747. Not going to work. To what extent are you performing the same operational tasks? The more and more we get computerized, the more and more the task is, I sit at a keyboard. You ever seen someone flying an Airbus A380? They're basically sitting at a keyboard. Kind of what someone's doing if they're in an emergency room, is they're spending a lot of time sitting at the keyboard. So maybe some of the tasks overlap. I would suggest that the basic purpose of deciding what order we see patients is a little bit different to the order we're going to land the planes on the runway. Not the same task. To what extent are we using the same physical tools? No. To what extent do we have the same teamwork dynamics? This is the only slight possibility. There was a suggestion at one point that the reason for a number of aircraft accidents was power gradient between captains of aircraft and co-pilots. And they tried to deliberately put in team training techniques to try to improve that communication when the captain was doing something wrong and the co-pilot who was more junior needed to call them out. Now, at the very surface, you can think, okay, I can see a parallel there to the surgeon's about to do something wrong and the nurse knows something that the surgeon really didn't know and the surgeon's not listening because they're a nurse. You can see a parallel maybe. Unfortunately, and here's the real kicker, none of those team training techniques in aviation worked. All the studies, they're terrible. There's no evidence at all. One of my students spent 6 months trying to do a literature review of crew resource management translated to other industries. And he had to give up when he realized that none of the crew resource management training courses even had the same objectives inside aviation. No one in aviation could agree what the syllabus was of CRM. And yet we had all these healthcare organizations saying, let's copy CRM. I've got no idea how they did it, because you do a basic literature review and you find out, we don't know what CRM is. How do we copy it? So, basically, if you think of, should healthcare be learning from aviation? Fundamentally on what helps safety, no, maybe. So what did healthcare learn when they made a deliberate effort to start learning from aviation? They copied across a few incident investigation techniques. Not the best and brightest. Right? There's a reason why incident investigation in healthcare tends to be called root cause analysis, because that's the kind of what most safety scientists criticize as the least smart way to think about incident investigation. But that's what it was called at the time it was copied, and once you copy something, you kind of stuck with the label. I don't want to say that what's currently root cause analysis is as bad as what was originally copied. There's been a lot of work done to improve it. Lots of different things have been tried to try to improve the methods of examining critical incidents. A lot of that is good work, I don't want to downplay it. What I do want to point out is you're still stuck with the dumb name of root cause analysis. Despite all that work, no one has been able to do something as simple as saying, this name is incredibly misleading, maybe we should change it. Increased use of structured risk assessments, unquestionably, aviation is to blame. Healthcare looked at aviation and thought, here are all these things that they're doing, let's do that as well. Use of management systems, also copied across, in some cases word for word. In some cases, you can still see the traces of accidental references in healthcare systems where someone's forgotten to de-reference the aviation recommended practice. And CRM. One very oddly specific, badly named, badly formulated method of team training. Now, I say none of this to criticize aviation. I say none of this to criticize healthcare. Let me take you back to the start of this talk. All of these things are copied from this side, not from this side. All of these things are copying that shadow picture that exists, not for the purpose of making work safer, but because aviation is a highly regulated industry, they had to develop a lot of practices to appease external stakeholders, in particular regulators. Healthcare has the same problem. These techniques are in fact adaptive. For example, they're very auditable That is something healthcare needs, because healthcare is in a regulatory environment, which is very audit heavy. These things are very good when a plane crashes and you need to explain why it's not going to happen again to the scared passengers. Healthcare has the same problem. These things are very adaptive. They're very good at helping organizations recover from tragedy. These things are very good at self-perpetuating and creating a clutter problem that healthcare is also facing. But let's go right back. I'm not here to tell you how to do safety. I'm here to tell you that the pattern repeats. And the particular pattern that I'm talking about here is the pattern of accepting things into your organization by copying them. And I'm telling you, why do people explain why they're copying? They explain on the surface that they're copying because they think aviation is better, they think healthcare is bad, and they're trying to remedy the gap. But aviation does the same thing. Railway does the same thing. Nuclear does the same thing. Chemistry does the same thing. They can't all be worse than the other industry and trying to remedy the gap. There's got to be something else going on. What is it that drives us to look outside our own organizations, thinking that someone else has got the answer? I think it's worth trying to examine what is that force. What is it that when we are the most professionalized organization, we have the highest number of staff with postgraduate degrees than any other industry. We have the highest focus of evidence-based practice than any other industry. Why do we feel that same desire to copy from people who don't have that? From people who've got folk practices that came out of nowhere? Why do we feel insecurity? Why do we feel a need not to rest on our own professionalism and to copy from elsewhere? I think if we could understand that feeling and understand where that impulse is coming from, that's where to start dealing with clutter. Not at each individual practice. Most of those individual practices don't work. Hit them one by one is just a game of whack-a-mole. Trying to get at the underlying insecurity and the underlying mechanisms that these things get into our organizations in the first place, I think that's where any sort of solution has to lie. This gets back to the paper we wrote trying to explain safety clutter. And lots of people sort of picked up the headline of that paper and ignored our underlying key message. Clutter doesn't exist because people do dumb stuff. And the way to get rid of clutter isn't to find out what's clutter and get rid of it. That doesn't work. That's why we wrote the paper in the first place. Clutter exists because of a fundamental asymmetry between how easy it is to implement safety things and how hard it is to de-implement safety things. And that asymmetry works on a number of processes. We have too many opportunities to implement, and many of those opportunities sneak under our normal safeguards that we use to prevent people doing dumb things in healthcare. We've got too many end runs that people can make. It always somehow feels safer to add something in than to get rid of it. People feel less secure when you take things off the checklist. But the evidence says that a shorter checklist is probably safer, but people are more worried about leaving it off. Training is more effective when we have fewer slides, but people are afraid not to cover all the points that they need to cover. It takes a certain amount of confidence to have 10 things that you really need to say, people really need to understand, and to say, stuff it, I'm going to go back to 2 because that's all the students are really going to take away from this. And those 8 other things they'll have to learn later. Maybe while they're on a ward, maybe while they're trying hard to kill someone. But training is more effective when you have fewer things you're trying to teach. So it's always very hard to strip back. It's very easy to add in. And we do this as individuals. We also do this as organizations. And I think the heart of dealing with clutter really is at this point, is it recognizing this and fighting hard on the other side of the equation, stopping people introducing things in the first place, having very strict standards for the evidence base needed to implement a safety practice, being willing to say, yes, something bad happened, but no, we're not going to add a procedure. No, we're not going to add a check. We're going to recognize that the bad thing shouldn't have happened, and we're going to recognize that we don't know how to stop it. We're going to live with that anxiety rather than having a knee-jerk reaction that we know is not going to be effective. To recognise that the auditor is wrong when they say, here are the 10 things you need to change. Maybe the path of least resistance is you just change those 10 things. Maybe you're making more work for yourself when you fight back. But you're making less work for everyone from then onwards who needs to manage that system. That's probably a good place, I think, for me to finish up and to pass over for questions.
That's brilliant, thank you. Thank you so much for a really inspiring talk. I think it got us really thinking about what some of the priorities are in this area, but also how we might have to have different conversations with those people who might be promoting the safety work that's going on. So I'm going to open it up to questions from people both in the room and online. Sobia, can you monitor chat if people want to add questions into the chat, or put your cameras on and put your hand up if you have a question? That would be fantastic. But I'll start while people are doing that with any questions within the room. Beth.
So I mean, that was like so inspiring and entertaining as well. So thank you very much for that. While you were talking, I was reflecting on the theme of work that me and some of my colleagues are just getting going with, which is called supporting safe care in the home. So I mean, it's probably the same in lots of different healthcare systems, but in the UK at the moment, we're looking at how you can provide care for people at home. So that could be hospital level care or healthcare that's always been provided in the home, and how we do that safely. And your 4 categories of how the 4 things that are different, it struck me that the main one is the physical environment and the equipment that we have, but also perhaps how the work is performed. And it started me reflecting on how do we then not replicate some of the problems that we now have in hospitals with too much going on and too much safety clutter, and then resist the temptation to export that into the home just as we're getting going with providing care. And I mean, there seems that there's lots of trade-offs to be made there.
No, thank you for raising that example. That particular one, but also the care industry more generally, is something that is very challenging for the way we tend to manage safety normally. And you did the same thing that I tried to do. So I tried to think through, okay, what do we actually have control over? And no, we don't have control over the environment. That's the biggest one. And the more I thought about it, the more I realized, okay, that is a trade-off that we've made. We've made it in part for economic reasons, but also in part because we genuinely think it's better for some of the patients that they do actually have that care in their own home. But the trade-off we've made is we've lost control of the environment, and a lot of safety comes from that control. So this is fundamentally less safe work. We have to live with that. We've made that trade-off decision already. Can we control the tools? Yes, this is where I think we need to be really clever, and where we've got most opportunity for genuine control. Is how do care people get hurt in homes? Very often it's because stuff's been installed in the home, or they go to the home thinking there'll be something there, and it's not there, or it's broken. But there is no way you send a carer to a home to bath someone. The lifting machine is broken, they do a risk assessment, and they say, sorry, live in your own filth for the next 3 days. Until they're not going to do that. They're going to try to do the work because they care about the person. And that's the fundamental trade-off that we forced that person to make. Because if we're going to have people in the home, we really need to invest in making sure either the people arrive with the tools, or the stuff that's in the home is very well maintained and is always there and always available and reliable, and that's going to be expensive. And that's going to change the economic calculation because it may be more expensive to maintain the equipment in those spaces than it is to maintain the equipment in the hospital. And it may not be as cheap as we think if we actually, but here's where I think we need to be really careful, and this is why the equation is important, is we can't say, okay, the only thing we control is how the work's done, so we're going to micromanage it. That's the least effective way of managing safety. We've already made the trade-off. We can't try to remedy all of that by now trying to overload people with procedures and risk assessments and so forth. The most we can do is have rules about lone working and make sure we've got the resources that someone always shows up with someone else, and that no one has to make that decision of, do I show up just by myself or I leave the patient uncared for? And we've got to make sure the resource and the redundancy is there. that we're not sending lone workers into those spaces. That's the most we can do. We can't try to micromanage the work. I'm not an expert in this space. That's just the way I thought about it when I tried to reason with it when I encountered it.
And also that to make sure that the tools or the equipment that we're giving people to use is
It's
designed
suitable for that
specifically for
space.
that space, rather than something that's just been taken from a hospital ward, or on the medicines that we're sending into people's homes are stable at the temperatures.
Exactly, yes.
Thank you.
Sorry, have you ordered food?
We have.
Okay.
If you just want to leave it outside, we'll bring it in.
I
when
need
we're
one
done.
of the trolleys, look,
Oh,
because
dear.
we're function in half an hour.
Sorry, no worries. We'll manage with the rustling in the background, if that's okay. Any other questions from the room? Alison?
I think when you were talking about use of language and the word clutter and why it's a good word to use, and us making words that feel safe to us, like the implementation. And also listening to you talk about the trade-offs that are going in, for example, when we're doing care in the home. How do we talk to, or I know you won't have an answer to this, but how do we best talk to patients about these issues as researchers? And also, do you think when we're looking after patients, whether we keep the trade-offs hidden from them, because tolerating uncertainty, they're already doing that usually on a kind of medical level, and there's this other layer of uncertainty on top. That makes sense. So it's how to talk to patients in this industry about it.
Yeah, I don't have the answer to that. And I think to a large part that is a context-specific empirical question that healthcare people need to work out for themselves, the best way to have those conversations. The only thing I think I can throw in a little bit is very often these trade-offs are either made explicitly at a high level or they cascade down to an impossible local choice. And I think we need to be willing to have the conversations up at that high level and to admit that we have, at an administrative, at a government level, made the trade-off. Rather than, you know, if you look at, and so I forget what they call them, the NHS has got like this set of contradictory values that they always espouse. And if you implement those at the local level, you cannot possibly give someone the best choice, the best care and autonomy at the same time. And you cannot possibly do both of those and run an efficient system. Someone's got to make that trade-off at a higher level, or the clinician right in front of the patient is going to have to make that trade-off, or push the choice onto the patient. That's not really a choice. It's not a choice if you say, well, we could leave you in the corridor, or you could get care at home. Yeah, it's got to be a real choice that we're making. I think we do need to be, I know I'm never a fan of anything other than complete honesty at the front line myself. But there are ways of presenting information that are helping with uncertainty. You know, very often when we think we're giving people risk information, we're just confusing them. That's not honest, that's just overload. So I'm not an expert in the right way to do it. I'm just compassionate for how hard it is.
Like, it just make me think about shared decision making when you can't really effectively put that into practice because of other things that are going on. So, thank you.
I'm going to come to Farhad in a minute, who's posted a question online, but you said something in your talk about the importance of exploring the origins of safety clutter, and that's certainly something that Hannah's going to be doing in her work, and that there was very little point in identifying and trying to reduce or eliminate low-value safety practices. We have actually taken that approach to some of the work we're doing because we're really interested to understand why people are continuing to do practices that are of low value and what value do they offer to them, which I think is part of your social safety elements of your work. And in doing some of that work, we're about to embark on a long piece of work looking at reducing double checking of medicines. The reason for that is because it just won't stop happening in healthcare when there's very little evidence it does provide any safety benefit, and it costs a lot of money. But there seems to be a need for evidence that it will not increase errors. And so we need to almost do that work and produce that evidence before people are going to be willing to stop doing it. So I really take your point and I agree with you, but I think there are a few occasions when actually particularly when the cost of doing the work is so great that we may need to demonstrate that it doesn't have any benefit.
Let me share with you something from our first large-scale decluttering trial. This, by the way, if you ever read the paper, one of our conclusions in that paper is totally wrong. We said that we thought the evidence base was a path to decluttering, and every trial has proved that's not the case. But we removed something that everyone agreed was nonsense and unhelpful. And what we found was that supervisors were telling their staff to replicate the form that we had removed, to replicate that information on other permits. They were doing that after the work was already performed. So this very clearly had no social function, but was important enough that the supervisors were making their staff do it. And our best explanation is that this is a social protection mechanism. I think with something like double checking, and checking I think is madly overrated everywhere as a mechanism of increasing safety. It's highly context specific when a check does or doesn't improve safety, but it's one of the most common things we do is just add a layer of checking. And we do this all the time with vehicle maintenance, with aircraft, also. But yeah, you've got to be really careful about when it does and doesn't. But what does a check do socially? It takes it from an individual responsibility to a system responsibility and makes sure that if there is an error, that one particular nurse is less likely to be hit with the blame. That is really, really important. That is worth spending millions on, preventing nurses being blamed from errors that are not within their control, even if it does nothing to reduce the actual chance of that error. And that's where I think we need to be careful about tinkering with things that have social roles. Is we may think the purpose of the check is to prevent the patient being on medication, but it may be what protects the nurse from an unfair accusation that they haven't been careful, they haven't paid attention, or they've been irresponsible. And that may be a necessary function of that process.
Yeah, I'm not sure it even does that because it just shares the blame between two people, but we
I mean,
can come
that's the
back
way
to
to
that.
remove it is to show them that in fact, two people get blamed instead of one. So it's not protection, maybe that might help to remove, I don't know.
So Farhad's question here, I've been following your podcast for a while and it's great to hear you speak. In healthcare, we have had a rise in different types of safety roles, incident investigators, patient safety specialists, governance leads, etc. What are your views on this fragmentation of safety into different roles based on your insights from other industries?
Oh, that is a really difficult one. It doesn't always go with clutter, but it does often go with fragmentation into multiple management systems, which is very much associated with clutter. It's very interesting that if you look at those roles, half of those roles that you listed there, Farhad, are not actually safety roles. Patient safety specialist is a role, but governance, like what is governance except a system on top of a system for the purpose of achieving something else? Having specialist investigators is, that is tricky because amateur investigators actually do a lot of clutter. But I'm not sure that having full-time specialist investigators is any better. No, I'm just going to dodge the question and say that yes, this fragmentation happens and it goes cyclical. People fragment, they bring things back together, they fragment again. There are obviously big institutional forces causing things to fragment and causing people to recognise the fragmentation and try to fix it by creating mega systems. And most people cycle between the two of them. It gets more and more cluttered as you cycle. But I don't have a solution to it other than, yeah, sympathy. It happens everywhere.
But it's interesting to think that there's not just clutter in terms of practices, but in terms of roles as well.
Yeah.
Any other? Oh, sorry, Ruth.
Thanks, Drew. Thank you. It's really good talk. Thank you. I'm just really interested at the moment around the trade-offs that you talk about people having to make, and some of those being things like organisations at national level, at all levels, really, decisions being made that don't necessarily invest in the environment, don't necessarily invest in the staffing, etc., things like that. And my experience on the project I'm working on at the moment is that when you speak to staff, particularly on the front line, they will very openly and explicitly talk to you about those trade-offs and the decisions that have been made that influence their ability to deliver safe care. I was just wondering if you had any advice or any experience that you could impart as to how you start having some of those discussions with higher levels of management, where they are also talking about some of those, having to kind of do some of that demonstrative safety and social safety and things like that.
Again, there's a lot of sympathy for the problem. I've got one slide that, just one particular picture that has been a little bit helpful in some of those conversations. And what it does is, sorry, I don't have it ready to show, but it basically talks about the horizons of risk that people are responsible for. And so like people at the front line are responsible for the risk right in front of them right now. At most, they plan their work a couple of hours in advance. Supervisors are typically responsible for decisions on a horizon of about a day. You know, supervisors will typically plan the next day's work in the afternoon of the day before or in the morning of the day before. They sort of look ahead to the whole shift. Managers and team leaders are typically, weeks and months. And when you get up to boards, their planning horizon is decisions that work over a couple of years. And where we get things going wrong is when people don't stay in their lane. So when we get senior managers expecting people to make trade-off decisions that aren't right in front of them. Yes, clinicians are going to have to make trade-offs all the time, but they shouldn't have to make a decision about allocation of resources, because that should already be made. But likewise, the board member should not be investigating that incident. If that incident was someone making a trade-off at a particular point in time, the board member should be focusing their attention on the big investment decisions. And any time the board member wants to look at an incident, they should be looking at it from the point of view of, this is my mistake because I didn't build a new hospital, not because I should be micromanaging the work. And so just pointing out, safety is everyone's responsibility, but not every safety is everyone's responsibility. It's a different horizon of risk people should be looking at and investing in and paying attention to. And it doesn't always get through, but sometimes very senior leaders don't know what they're supposed to do for safety. They just really struggle to understand, and that causes them to micromanage. And so when you put into their heads, okay, your job is safety in 2 years' time, what can you do for that? That puts it back into a framing of decision making that they're used to making other decisions about. And so it at least gets them out of micromanaging. I don't know if it actually helps with the investment decisions. But I think it can also help sometimes is the guilt that local people feel when they realise that actually, no, I'm living with a decision that's already been made. I'm not making a bad decision here. There's so much burnout in healthcare because people they think they're sacrificing their values when they're simply making a trade-off that isn't, they're not making that choice. That choice is already made.
I'm going to say no because it's 1:30, but you will be chatting to Drew later, so you can probably ask it then, Ruth. Save it for then if that's okay. I just want to finish by saying thank you so much. You've really got us all thinking, Drew, and we'll be taking this away into our future work. So thank you for coming and visiting us today. And thanks to everybody online and in the room for attending. Thank you.